We may still be missing a few folks, but they can join in as we get going. So this is the first time I'm actually getting to talk to all of you guys, the residents as a whole group. So it's really nice to meet you all, even virtually. I am really excited to be here. I wish that we could be in person and see each other's faces. Pandemics are the worst. And also Zoom lectures kind of stink. So this lecture is usually a very kind of conversational lecture. It's very much clinical and to hopefully help you when you're actually seeing patients in real life. I even often do it kind of as a chalk talk and just kind of talk through joint pain and how I think about it. So I'm going to do my best to translate that to Zoom today. Whitney sent out a handout that hopefully you guys saw this morning. If you want to kind of fill it out as we go, if that's helpful to you. If not, don't worry about it, no big deal. But I thought that might be a way at least to kind of help you make connections and remember things we talk about. So this is my little family, and I can't wait to really get to know y'all and hang out in person once COVID gets a little more under control. All right, so really this is our one big objective today, to understand patterns of joint pain to help guide your differential diagnosis and evaluation when you're seeing patients in clinic. There are definitely going to be pearls that will help you for boards and things like that, but I really wanted this to be kind of a clinically based lecture. So we're not going to talk about these much today, but I wanted to throw this up here to start, just to say that there are lots of causes also of non-joint musculoskeletal pain, of course. So, you know, thinking about things in the skin, muscle, bone, nerves can all cause musculoskeletal pain. It's not necessarily joint pain, but just to make sure you're thinking about these things when you're seeing patients as well, and really teasing out where the patient's having pain to help direct your differential diagnosis and your evaluation. All right, so if you guys want to look at that handout that I sent, so I made this kind of flow chart to think about joint pain and kind of different branch points for you to think about it. So we're going to kind of go through and talk about some categories that are more or less likely for each of these different branch points. So when I'm thinking about categories, what I mean is kind of broad. So first, so in that top left kind of list of things, these are going to be your options when we're going through the different parts of this tree. So infectious causes of joint pain, post-infectious causes of joint pain, mechanical, autoimmune, and neoplastic. So almost all causes of joint pain can be put into one of these 5 categories, and they're each kind of more or less likely based on the pattern of the presentation of the pain. So that's kind of the framework that everything is going to sit in today. All right, so the first branch point that we're going to think about with joint pain is whether it's monoarticular, just one joint involved, or polyarticular. And this really, for the purposes of this lecture, I'm either talking about one joint or more than one joint. Don't be confused by the definitions of oligoarticular and polyarticular juvenile idiopathic arthritis, for which the cutoff is 5 joints. Today, we're going to focus on one joint or more than one joint, because we're going to talk about things much broader than just JIA. So then within monoarticular or polyarticular, we're going to break it down by whether there's actual arthritis in the joint or whether there isn't arthritis in the joint. So to make that distinction, you have to be able to say, what is arthritis? What is the definition of arthritis? How am I going to know if there's arthritis? Does anybody want to take a crack at that? I know it's kind of hard to interact since y'all are often in kind of groups, but if anybody wants to throw it out there, either unmute yourself or in the chat is fine too. And if I have no takers, I'll just keep talking at you. It's just more fun when I can pull y'all in, but if not, I know Zoom is weird, so it's totally fine. So, woo, went crazy. So my definition of arthritis is painful, limited range of motion. So it is not just arthralgia. To have real arthritis, you have to have that painful, limited range of motion. Often there's an effusion. You can usually, well, not usually, often you can feel the effusion. Sometimes it's small and hard to feel, and in smaller joints certainly can be harder to detect.
Wait, did we get the keywords?
There's often warmth in the joint when there's arthritis, and often stiffness. So to tease that out, I'll ask about mornings, whether they wake up with morning stiffness, or sometimes after a long car ride, if they feel stiff. For babies and toddlers, I'll ask about mornings, specifically if they're just cranky in the morning and want to be held, can often be a sign of morning stiffness. And the other thing in kids with arthritis, before they even really complain of pain, sometimes parents will just notice a change in the way that they're behaving. So a change in the way they're using their joints or a change in their gait. So I ask about those things as well. And y'all feel free to pop in with questions too. All right, so we're gonna start with our first category, which is gonna be monoarticular, one joint that has arthritis. So of those categories that we talked about, infectious, post-infectious, mechanical, autoimmune, and neoplastic, what do you think, which of those do you think would be most likely in a patient with monoarticular arthritis? Anybody? So when I think about monoarticular arthritis, the big three that I think about are infection, autoimmune, and then mechanical reasons. Post-infectious and neoplastic are possible, but less likely than infectious, autoimmune, and mechanical. So within those, I'll break it down a little bit more into the differential. And again, if we were in person, I'd have you guys throw these out at me, but I'll just kind of go through them to help kind of jog your memory. So infectious causes can be bacterial, you know, your common strep, staph. I'm not going to go through all of these for you today. Gonococcal arthritis can also cause a monoarticular arthritis. And Lyme. We don't have much Lyme in South Carolina, but getting a travel history to think about whether they've been to the Northeast or, you know, Minnesota or somewhere that has more Lyme than we do can help with that distinction and whether you need to go down that path of sending Lyme serology. Autoimmune, of course, JIA would be the most likely. And then mechanical, there's lots of things that can give you real arthritis in a joint. So any reason that you could have a hemarthrosis, so whether you have some kind of bleeding disorder, synovial hemangiomas can cause hemarthrosis. Discoid lateral meniscus can mimic inflammatory arthritis. Osteochondritis dissecans. Tarsal coalition in the foot can cause a limitation of range of motion in that subtalar motion. Schiffes and Perthes disease. Neoplastic, again, less common, but especially a couple of benign growths like synovial chondromatosis, where you get these little blebs of cartilage that form in the joint, can be very painful. On x-ray, it looks like a nest of all of these little blebs of cartilage. And pigmented villonodular synovitis, which we call PVNS for short because it's way easier, is a benign growth of the synovium that can cause hemarthrosis, can mimic arthritis as well. Post-infectious is less likely to be a monoarticular arthritis. Of course, there's transient synovitis of the hip that we think about. And sometimes post-streptococcal arthritis could give you one joint. And especially if a patient is taking NSAIDs that would inhibit the migration that you can see with something like acute rheumatic fever, could possibly present in one joint as well. All right, so history is really going to help you to differentiate which of these seems more likely. Thinking about the time course, infectious things are going to come on more suddenly. Autoimmune and mechanical are going to be kind of more subtle over time. So the time course will help, the characteristics of the pain will help, and looking for any other accompanying symptoms that may be going along with it. All right. So next, we're going to go to monoarticular, but there's no arthritis. So they're having pain in one joint, but there isn't that limited range of motion effusion that you see with arthritis. So mechanical is by and large going to be your most common cause here, kind of followed by everything else. So in this category, really would focus your differential on mechanical causes. So there are lots of these. So some of the ones that we mentioned in the last slide, Perthes and Skiffy can present this way in addition to presenting with potentially limited range of motion. And just all of your kind of overuse injuries, which I will leave to kind of your other sports focused lectures. You can get an osteomyelitis that could be near a joint that could present like this. Neoplasms, of course, always have to be on your differential, things like Ewing's and osteosarcoma. Post-infectious joint pain in a single joint without arthritis would be rare. And autoimmune causes of just joint pain without real arthritis would be rare in a single joint also. But CRMO near a joint could do that. All right. So here's one example of one of the things we just talked about. So this would be a patient presenting with pain in one hip. Anybody have an idea of what this is? I'm going to throw it out there. I know you're there. So this is Perthes disease. So you can see the femoral head is not happy. So avascular necrosis of the femoral head. All right. Any ideas about what's going on with one of these hips? So this is a Skiffy, and it's important to catch it here before it goes to here. And if you'll remember the kind of radiographic finding that you're looking for when you're worried about Skiffy, it's looking at Klein's line. So if you draw a line kind of parallel with the femoral neck here, it should intersect with your the head of your femur. So here it's starting to slip downward and Klein's line no longer goes through the head of the femur. So if you were to draw that line here, you would see that it doesn't bisect like it does on this side. So this is a surgical emergency. If you see this, you call ortho right away. Like I saw one of these in clinic in fellowship, and called ortho, and they said, tell them not to bear weight and to come to this OR in the morning. So they will take care of it urgently. All right, questions about the kind of monoarticular side of the tree? Anybody? All right, so we'll move on to polyarticular.
I have a question.
Yeah.
For Skiffy, these kids will come in and like have oh no, I'm having this pain for 3 weeks or a month, and then all of a sudden it's a surgical emergency. Like, what's the time frame on, like, why is going one more day is so bad when it's been going on all this time?
I think because they have the risk of having it really slip like this, which, you know, is
That,
way
sorry.
worse than being in this situation.
So you probably don't go gradually from A to B. You're at A for a while, and then all of a sudden you get to B, and that's the big problem.
That's my understanding.
Okay.
You know, if Dr. Holloway is on here, maybe he can chime in. He said, because you know A.
I saw that.
So yeah, you know, I think that's the main thing, is you're trying to prevent this from happening.
Okay, thank you.
Yep.
I was gonna type it, and then it's basically because you know about it, and so any further progression could be worse. So it's not really a surgical emergency as much as it's urgent that now you know about it, you should treat it, because if it slips any, you know, any amount of slip after you've documented it could be bad.
Definitely. Cool. Thank you. All right. Any other questions?
I have a question.
Yeah.
Okay. So I thought the definition of arthritis was that it was painful, but that there was like a limited range of motion. Okay, but then a skiffy is not an arthritis?
So it can be in the painful limited range of motion category, or sometimes it can just present with hip pain and you don't really have limited range of motion yet.
Really?
I would say it could fit into either of those categories.
Okay.
Does that make sense?
It does. Thank you.
Okay. All right. So moving on to polyarticular causes of joint pain. So post-infectious and autoimmune are going to be your big two here in the polyarticular with arthritis category, kind of followed by everything else. So when I think about post-infectious, the post-strep causes of arthritis, so that can either be just post-strep reactive arthritis or acute rheumatic fever. Your enteric organisms, you'll remember, can give you a post-infectious arthritis. And then parvovirus is another big one that I see a lot. So teasing out that history of this slap cheek or the lacy reticular rash, and especially if they have involvement in small joints. Next, of course, are your autoimmune causes of polyarthritis. So polyarticular JIA, lupus, mixed connective tissue disease, drug-induced lupus can all have polyarticular arthritis. Vasculitis can give you arthritis. Inflammatory bowel disease can give you arthritis. And sarcoidosis, both the childhood onset sarcoidosis and the adult type sarcoidosis that can have that can start in childhood, both. Neoplastic causes are possible as well. Leukemia and neuroblastoma can both give a polyarthritis. And so that's one reason why in any kids with new diagnoses of arthritis, you know, I'm getting some screening labs to make sure there's nothing else that looks fishy. Infections like gonococcus, streptobacillus, Rocky Mountain spotted fever can all give a polyarthritis. And then any of the things that can be bilateral could be polyarthritis in the mechanical category. Again, that's why it's at the bottom of the list. It would be less likely, but you can have bilateral skiffies. You can have bilateral perthes. You can have bilateral tarsal coalition, are all possible things that could fall in the polyarthritis category by being just the same thing on both sides. So migratory polyarthritis is definitely kind of its own special category. So when you hear migratory polyarthritis, either on a test or in real life, I want you to think about rheumatic fever. There are very rarely other things that will migrate. And when I say migrate, I mean on Tuesday, I had painful limited range of motion of my wrist. On Wednesday, my wrist was fine and my right knee was had painful limited range of motion. So it's truly going from one place, that place gets better, and you have a new place that's involved. It can be hard to tease out sometimes whether something's truly migratory or if it's additive. And depending on how good your historian is, can especially be hard to tease out. But I just want you to always trigger in your mind rheumatic fever. HSP sometimes could do this, can give you a migratory arthritis. The arthritis of HSP tends to be more periarticular swelling than true joint effusion, but maybe a mimic of this, especially can be confusing if the arthritis pops up before the characteristic rash does. And the last thing that's in this category potentially is Lyme. So again, not common around here, but if you have somebody who just moved from Connecticut and they say, you know, I had knee pain for a couple months and it was swollen and then it went away and then my other knee swole up for a couple months. This tends to be kind of a longer time course of migration than the rheumatic fever category. IBD can occasionally do this as well, and leukemia, but rarely chronic rheumatic disease. So, you know, someone with lupus or JIA is rarely going to migrate. Usually those patients, if they develop arthritis, it's going to stay there until we do something about it. So if you have things that are kind of getting better and going away on their own before you get problems somewhere else, that's less likely to be a chronic rheumatic disease. In general, these are a couple things that I think are good to know about this category. And that is that if you have arthritis that comes out of the blue like that, sudden onset, it typically also will have a sudden resolution. Rarely I've seen JIA kind of come out of nowhere, but it tends to be kind of more insidious. Post-infectious arthritis tends to happen like this and then go away like this. And it's also typically very responsive to NSAIDs. So that sometimes, you know, helps my diagnosis. If I have somebody do a trial of NSAIDs and their arthritis disappears, I feel much more comfortable about it being a post-infectious issue. All right. ALL is something else I wanted to kind of bring up, some of the specific characteristics of this, because it's in the less likely but you don't ever want to miss category. So nighttime pain is really important and seen often in ALL, but also they have daytime pain as well, which would be something that would differentiate it from growing pains, which we'll talk about in a minute too. The pain is usually out of proportion to what you objectively see on exam. They can have metaphyseal tenderness, so kind of right outside the joint. And of course, this is the importance in just getting some screening labs. So you'll see that lymphocyte predominance. They'll often have relative thrombocytopenia. If I'm worried about an inflammatory arthritis, I would think there would be more likely to be a reactive thrombocytosis. So if I see low or even on the low side platelets, at least triggers in my head to think about leukemia. And of course, this is a reason why it is not the best idea if you have someone with joint pain just to say, oh, let's trial some steroids and see how it does. Because if you give patients with ALL steroids, it has the possibility of putting them in that higher risk treatment category if they've been on steroids prior to starting their chemo. All right. Moving on to polyarticular joint pain without arthritis. So this is something we see a lot. Think to yourself for a minute, what do you think would be the most likely cause of pain in lots of joints without arthritis? So mechanical, and mechanical would be the top three here, followed by kind of all of our other categories are possible but less likely. And when you're thinking about those other categories, sick versus not sick is definitely an important distinction to make. Your mechanical joint pain patients are definitely going to be in the not sick category. If you have any kind of other systemic illness kind of stuff going on, you need to start thinking about the other categories. So thinking about mechanical, something we see a lot is hypermobility causing joint pain. So, you know, these will be the patients that can extend their elbows past 180 and their knees go backwards when they stand up. Their fingers will bend back. There's the Beighton criteria, if you've heard of those. If you come hang out with me in clinic at all, usually at least once a day, I find somebody who probably has hypermobility contributing to their joint pain. And then kind of the pain amplification syndromes. So things like fibromyalgia and other causes of pain amplification. Neoplasm, like I said before, you have to think about, especially if they have any other kind of sick symptoms going on. Post-infectious causes can give you some arthralgia, especially in acute rheumatic fever. Arthralgia is one of the minor criteria, one of the minor Jones criteria if you don't have true arthritis. So just having arthralgia is a possibility there as well. Autoimmune, again, CRMO might cause this. And some causes of infections, viral illnesses can just kind of give you generalized joint pain, make you achy all over. But again, that's generally going to be kind of more short-lived. All right. I don't know how this blue got on here if I did that, but I'm sorry. Can you guys see that blue squiggle? Is it there for you? Okay. Let me see. Yeah, I can't erase it. Okay. So when you're thinking about history, duration is going to be really important. So the autoimmune causes of joint pain, like the definition for a JIA is that it has to be there for 6 weeks or longer, and kind of getting a good idea of the rapidity of onset. Kind of, did it start suddenly? Did you notice it over time? That can really help you as well. Fever, of course, is important to ask about. Migratory versus additive, like we talked about before. Whether it gets better or worse with activity. So thinking about the inflammatory causes of arthritis, you get that joint stiffness that gets better actually usually once you get up and get moving. Things like hypermobility tend to get worse with activity and be worse at the end of the day. Nighttime pain, like we talked about, is concerning. Getting a good history for swelling and the limitation of motion, and then kind of thinking about what makes it better, what makes it worse can help you tease out these things too. So I see patients a lot in clinic who you know, they say, I thought this was just growing pains, or their pediatrician said they thought it was growing pains. So I wanted to kind of go through what the kind of rules I use for growing pains. And so kind of if you don't fit in this kind of clear cut, you know, definition of growing pains, you need to be thinking about other things. So this is pain that is not there during the day. It's only at night. The child does not have a limp. They do not limit their physical activities during the day due to pain. It's typically symmetrical. And when you see them during the day, their physical exam is normal. These do tend to be kids that have some hypermobility. And systemically, they're well. They're not having fevers. They're growing well. And they have normal gross motor milestones. This also tends to be in the kind of school age range, occasionally toddlers. But outside of that age range, I wouldn't usually think of your normal growing pains. Another feature by history that I see a lot for growing pains is that if the parent rubs it when the kid wakes up in the middle of the night with the pain, it makes it better. But yeah, if you are seeing anything other than these things, I would be careful about attributing the pain that you're seeing to growing pains. All right. In rheumatology, we take long reviews of systems for everybody, kind of thinking through all of our systemic diseases. So in joint pain, that's no exception. So asking about, you know, a lot of the symptoms that you can see in things like lupus, can see in other autoimmune diseases like dermatomyositis, can see in IBD. These are all important to ask about for patients with joint pain, just to make sure you're not missing some of the other autoimmune causes. All right, And then when you get to your physical exam, remember your definition of arthritis. And I would also say, remember to examine all the joints. So like I mentioned earlier, kids won't always complain of pain at first. So there's often times that I find arthritis in joints that kids haven't even complained about yet. So even if they come in with knee pain, you're looking at all the joints to make sure there's nothing going on in other joints that would put you in the polyarthritis category and make you need to think about a different differential. Septic arthritis generally doesn't have any painless motion. So they're going to want to hold that joint stiff. They don't want you to move it at all. It's red, it's hot, it's angry. JIA is more pain at the extremes of range of motion. So it may be limited, but generally you can have some painless motion until you kind of get to the end of where they want to go. Then you're more likely to elicit pain. So thinking about duration can be tricky, especially in little kids, like I said, who may not complain of pain at the beginning. So one thing you can look at is limb length. In inflammatory causes of arthritis like JIA, you will get limb length discrepancies. This is something that they like to trick you with on board questions. So early on in the course of JIA, the affected limb, because of the increase in blood flow to that inflamed joint, will grow longer. With time, though, that increased stimulation to that joint, increased growth, will make the growth plate close earlier than the unaffected leg. So at the beginning, it may grow longer, but then the growth plate will close earlier and it can end up shorter as the other limb continues to grow. So that's a little bit tricky. It could either be longer or shorter depending on the duration, but having any kind of limb length discrepancy at all can be a hint that this has been going on chronically. Muscle atrophy is another helpful finding on physical exam and can actually happen pretty quickly within just a matter of weeks. So especially in say a toddler with knee arthritis or ankle arthritis, I'll often see atrophy of their thigh or their calf because of changes to their gait and changes in the function of that leg just in a matter of weeks. Contracture can also be a hint that something has been going on a long time. So here is a good example of a leg length discrepancy. This knee is obviously bigger and looks like it probably has an effusion. And you can see they're kind of standing with this leg popped out, and I think you can appreciate maybe with the knee even a little bit bent to accommodate for the extra length that you have in that leg. Oh, and here I wanted to show you this is the Beighton criteria for hypermobility that I was talking about. My old mentor used to say that this tends to have a high rate of positivity in medical students and residents. I definitely have hypermobility and can do most of these things. But it's good to kind of go through these, can they bend over and put their hands flat on the floor? Can they flex their thumb down to their wrist? Does their pinky go to 90 degrees? Can you bend your elbow backwards past 180? Can you bend your knee past 180? And you add them up. So you can have a maximum score of 9 if you can do all of these things, 1 for each side of the limbs and then +1 for the forward bend. And I think it's a cutoff of like 5 or 6 to qualify for being hypermobile. All right. So one of the important distinctions you have to make, like I said earlier, is sick or not sick. And that's why in any kid with joint pain, pretty much, I'm going to at least get a CBC, inflammatory markers, and screen with plain films. There's so much that you can learn just by doing those things. You're screening for malignancy, you're looking for evidence of systemic inflammation, and getting plain films will help you with some of the mechanical things, but also just making sure there's not something sneaky there like CRMO, like a malignancy. So this is kind of my first tier for anybody with joint pain. All right. We are going to do a few cases in the time that we have left. But before we get to those, any questions about kind of the polyarthritis category and thinking through physical exam and first tier testing? Okay, I'll move on to cases. So case one, this is a 4-year-old girl who has a 2-week history of knee pain and morning stiffness. She had a sore throat a couple weeks ago, but her rapid strep and throat culture were negative, but they treated her with amoxicillin anyway. She's been afebrile. At her PCP, they examined her knee and thought that she had an effusion, thought that it was warm. She didn't have any erythema, but she wouldn't fully extend her knee. So somebody throw out there what categories you think are most likely and kind of what you would do next. So this is a monoarticular, right? She's just presenting with one joint and she has arthritis, right? She has painful limited range of motion. So we need to think about infection. We need to think about autoimmune causes, and also probably need to think about some mechanical causes. So the next steps would probably be my first tier stuff, right? So get an x-ray, get a CBC, get inflammatory markers. So on x-ray, you can see that she has an effusion. Her CBC is significant for maybe a little anemia. Her platelets are on the high side, so that's making us feel, you know, a little better about it not being a malignancy. She's super inflamed. With this history of strep, you got an ASO, but it was normal. But then she got a fever. So made us a little more worried about infection, okay? So they decided to tap her joint. On arthrocentesis, you've got some whites, but more reds. So she's a little inflamed, but not crazy infection inflamed. So they send her to rheumatology clinic. And in rheumatology clinic, you examine all the joints because that's what we do in rheumatology clinic every time. And you notice that she can't extend her neck. She can't extend her elbow, and she has thickened synovium in her elbow, and she has a swollen toe PIP as well. So actually was a polyarthritis masquerading as a monoarthritis. So this was a case of JIA, and her ANA test ended up being positive. And you're going, what? ANA? We didn't talk about ANA. Why did you get an ANA? So if this again could be a whole lecture in and of itself, but ANA, I often see patients who have joint pain who've had an ANA sent, but the ANA is a very non-specific test. So it's not going to rule in or out arthritis. It might help you with lupus, but certainly in a patient with JIA, we're not going to use it as a deciding factor to say yes or no, this is JIA. Not all patients with JIA have a positive ANA, and also ANAs can be positive in 20 to 30% of completely healthy kids. So the reason that we check an ANA in patients with JIA is to stratify their risk of uveitis. So you know that uveitis is the other, eye inflammation is the other organ system that can be involved commonly in kids with oligo or polyarticular JIA. And one of the main risk factors of that is if you have a positive ANA. So those kids will need screening more often for eye inflammation if they have a positive ANA. Questions about that case before we move to the next one? All right. Case 2 is an 11-year-old girl who's been complaining of knee pain during basketball season. She's like, I I don't really remember exactly what happened. Maybe I kind of twisted my knee one day, but it started hurting, and I can't extend it all the way. So you see her on exam, you're right, you can't extend your knee all the way. She might have a tiny knee effusion. She does have some quadriceps atrophy, and she has a negative McMurray's sign. So you're thinking maybe with this basketball history, have you torn your meniscus? McMurray's test, if you remember, is one that looks for meniscal tear by kind of applying pressure to the joint and rotating to see if they have pain with that movement. So you're like, all right, let me think about this. It's another monoarticular. She has painful limited range of motion. So let's start with our normal stuff. You get a CBC, it's normal. Her SED rate is 7. Maybe she had some risk factor for Lyme. Your Lyme serology is negative. Somebody sent an ANA, it was positive, but the remainder of her specific antibodies on the rest of the ANA panel were negative. So you get an X-ray, that's normal. So you presume she has JIA, which is reasonable, right? She has painful limited range of motion in one joint. You decide to start her on some NSAIDs to see if that helps. You aspirate the joint, and it's a bit bloody, but there isn't a significant amount of inflammatory cells. And then you inject her knee with a steroid, which is often what we'll do in oligoarticular JIA, is especially if it's just 1 or 2 joints involved, inject it with a steroid, see how they respond to that before starting more systemic treatment. So she got a little better after her steroid injection, but she was never pain-free. Her effusion improved some. And so it says repeat MRI, but sorry, it's actually the first MRI. So this is what you see on MRI. Any guesses of what this is? So this is a mechanical issue at heart. It's called lateral discoid meniscus. So it's a malformation basically of your meniscus that's thickened like this, that causes pain and stress in the knee joint. So this is an orthopedic issue. Can mimic JIA though. So good to look for in patients who either don't respond to treatment for JIA or have other things that make you suspicious that it might not be JIA going on. All right, third case. So this is an 8-year-old Vietnamese female. She has bilateral knee pain that she started complaining of while they were on vacation in Chicago. So her parents are like, you know, we really just thought it was because we were walking around everywhere. Didn't worry too much about it. She started getting some knee pain and swelling. So they gave her some naproxen, which helped a lot, they said. And she also had fever for a couple days and a couple days of emesis, just kind of really not feeling well. And so kind of the fever and emesis resolved, and they're still giving naproxen every once in a while. And they started noticing she complained of ankle pain as well. The knees got better, but now she's having some ankle pain. So what is this making you think about? So she's definitely got some infectious kind of symptoms, right? Fever, emesis. It's responsive to arthritis. It's responsive to naproxen. And I'm a little bit worried that the fact that she's kind of moving from joint to joint and having ankle pain makes me worry this might actually be migratory. So lo and behold, she starts breathing fast and her parents are worried about it. So they take her to the ER. Where she's tachycardic and has a significant murmur. And her ASO is through the roof, so sky high. So this isn't a case of acute rheumatic fever with cardiac involvement. So definitely declared itself eventually. Not everybody with acute rheumatic fever will have cardiac involvement. But I think that a takeaway point here is that naproxen can kind of mask the migration of the joint pain. So getting a good history about what NSAIDs they're using is important. All right, last case. So this is a 21-month-old female who's presenting with a limp. She's kind of favoring her right leg, but she's still walking around. She's been afebrile, and really on physical exam looks normal. So she doesn't have any swelling, no pain with motion, no limitation of range of motion. So this would go more in your monoarticular non-arthritis category so far. So you get an x-ray of her hips and her lower extremities since it's a little bit hard to kind of differentiate where she has pain. And she just kind of gets better. So she was walking without a limp. And a month later, she starts limping though and favoring the other leg. On physical exam, she still doesn't have any arthritis. So you decide, okay, this is weird that you still have stuff going on. Let's get some more labs. So her labs are significant for, she's pretty anemic. She has a high SED rate. She goes on to start having fevers. Still never really had arthritis, but is still limping. And with further evaluation, actually, she ended up having neuroblastoma. So a good example of keeping your differential broad whenever it's kind of falling out of that. So that's a patient that I think could have been easy for someone to say, oh, you're having growing pains. This pain is kind of coming and going. But when it's happening during the day, when it's changing the way they walk, when you have any abnormalities on your labs, you really need to start kind of thinking outside the box. All right. So I think I hit most of these take-home messages. History and physical is key. Classifying monoarticular or polyarticular, presence or absence of arthritis. Duration is the other really important aspect of your history. Doing a complete review of systems. Really learning your joint exam. So I would love for y'all to come rotate through rheumatology with me. I will teach you a joint exam. You'll feel better about it. I know it's something that often can feel kind of foreign if it's not something you're doing every day. And then kind of thinking carefully about some labs that can really be helpful to you. All right. And that is all I have. Was it important that the rheumatic fever child was Vietnamese? No. That was just the way it actually happened. Those are all real cases. Other questions?
This is Bethany. I have a quick question.
Yeah.
I think I had another rheumatologist tell me at some point when I asked about when it's appropriate for a primary care pediatrician to order an ANA, then I had heard that, like, unless you're 95% sure this child has lupus, you could just send them to the rheumatologist and let them decide what to order. What are your thoughts?
I think that is a pretty fair statement. And I say that not because I have some, special knowledge of how to interpret ANAs, but just more that most of the time it's not going to be that helpful. And if you really are worried about lupus, I am much more concerned that you're checking a urine to look for nephritis, you're checking their blood pressure, you're looking carefully for rashes, you're looking carefully for joint pain, you're really looking at their CBC to see if they have any cytopenias. There are lots of other pieces of the puzzle that are way more important to help you decide if you need to send them to a rheumatologist to worry about lupus. If lupus is number one on your differential because you are seeing those things, then yeah, by all means, send the ANA. But almost all of our other diseases, an ANA isn't going to help you rule it in or rule it out. So, the one example of using it to risk stratify for uveitis, we'll send it for that. But that is not something that's going to help a primary care doctor decide whether or not someone's joint pain is autoimmune in origin. Does that help?
Yeah, that's really good to know. Thank you.
Mm-hmm. Other questions? All right. Thank you, guys. I hope that wasn't too dry. Like I said, I usually really like to have more kind of conversational lectures. So I hate just talking at you, but it's the best we can do with Zoom. So I hope it was still helpful. If you guys think of other questions, call me, text me, email me, come hang out in Rheumatology Clinic. And everybody stay healthy. Thank you guys.